Let me start to introduce Rania Awaad. I think it's a privilege that we have you here tonight. Rania Awaad is an associate professor at Stanford University for psychiatry and behavioral medicine. She's practicing she's a practicing psychiatrist also, and working in the Department of Community Psychiatry. But she's also the director of the Stanford Muslim and Mental Health Lab, providing mental health for Muslim men and women, maybe only women, I don't know, he will tell us, and also doing research in this area. She also worked amongst refugees in the Middle East, and now she's gone. Okay. Oh, she's back. Okay. And she's going to speak to us about religion and suicide prevention in Muslim mental health. I think this is great. We have she will give us another perspective and in another specific religious area. And we are looking very much forward to you, Rania, and to your presentation. I hope you still hear me. So I hand over to you. Thank you a lot for being here tonight.
Thank you so much for having me. I appreciate this very much. I wish I could have been with you in Amsterdam today, although as you can probably hear from my voice that I am under the weather, and it is probably best that I am distanced from you today. I hope that you will bear with me as I go through this presentation and excuse my voice. Today I'll be talking about understanding suicide in American Muslim communities. And as we discussed, this is a perspective in which we're looking at a particular, more marginalized community in the United States. In order to start, so that you know where the information is being drawn from, I like to share resources at the beginning and at the end. Our website for the Muslim Mental Health and Islamic Psychology Lab at Stanford University, I hope will be a resource for all of you. This particular lab has multiple lines of research, one of which is particularly dedicated to the topic of suicide. But there are multiple other lines of research for Muslim populations, such as global mental health, women's mental health, aspects related to substance abuse, and others related to other forms of mental illness. A little bit of a preface as to why we ended up working on the topic of suicide, which is difficult, and why I'm going to give a trigger warning right at the beginning of this now, because what I will be sharing next is difficult. And so if it is something that is difficult for you, I encourage you to take a step out, give yourself some time, and when you're ready to join us again. I just want to make sure the sound is coming through, because there's some comments in the chat. Are this both the sound and slides coming through? Okay, excellent, thank you. About a year ago, there was a tragedy in Dallas, Texas area. And since then, and before then, there have been multiple tragedies, but certainly the tragedy of last year. And since then, as you know, the state of Texas has had many, many unfortunate tragedies since. There was a tragedy that struck the Muslim community that really, in many ways, was eye-opening to Muslim communities across the United States and globally. It's a story of suicide homicide in which there was very untreated mental illness in two young men who were part of a family who made a pact amongst themselves that because they were so distressed that they would take their life, but they would also take the life of all of their family members along with them. And in this tragedy, 6 members of the family all perished. And it became very clear that the untreated mental health conditions that could have potentially been prevented and treated actually then meant that this case could have also have been prevented. For those of you who are familiar with the topic of suicide and its research, you'll know that there is a topic called suicide contagion. After this incident happened in Dallas, Texas about a year ago, there has since been a contagion effect amongst the same age group of people in that location. And this is exactly what we suicidologists worry about. We worry about the fact that others may see this as a way out too and do the same. For many years in our lab, we had actually been working on the topic of suicide because clinically, we saw that the numbers were on the rise. In the community clinics that work with marginalized communities, not just Muslims, we found that the numbers were really high, actually, for suicide attempts. 1 in 3 people coming in for therapy were reporting suicidality in the clinic. But we had no data points at all if we isolated the American Muslim community, how that community was actually doing. And that launched a study within our lab that then led to a publication in JAMA. JAMA is the Journal of American Medical Association, and this was in JAMA Psychiatry. What we published was something that really turned a lot of heads. It was published in July of last year, and it related to a comparison of Muslim Americans to other faith groups, Christian, Jewish, Hindu, Buddhist, and also non-religious groups, atheists and agnostics. The finding was quite surprising. We knew the numbers were up as researchers and clinicians, but we didn't quite expect that it would be double the rate of other faith groups and non-faith groups. When this was published, there was clearly a lot of interest in the topic because there was a question about why. Why was this the case? And why in similar marginalized communities this is the case as well in the United States. I'll first share with you a little bit about the study design, and I'll come back to the question of why. To share with you a little bit, this particular study was conducted with ISPU, which is the Institute of Social Policy and Understanding. This organization puts out every year something called the American Muslim Poll. And it asks a series of questions, and it's a cross-sectional survey, which they oversample for the Muslim population, but they talk to people from all different backgrounds. Before the pandemic in 2019, we added some questions from the Columbia Suicide Scale and other mental health questions to the survey. Because in the social political atmosphere prior to 2019, in that last administration, there had definitely been quite a bit of turmoil within this community. Many people felt that the Islamophobic rhetoric was very high, and this caused quite a bit of difficulty, but there was no real data to pinpoint and to show the correlation. Although anecdotally, we could tell you in this community that there was definitely an effect on mental health conditions. In 2019, we also published a book called Islamophobia and Psychiatry. And this was the first time in the literature we were able to make a direct correlation between Islamophobia and mental health, detrimental mental health conditions within this community. And so in the American Muslim poll, the data was collected, as you can see, right in the height of the pandemic. It was collected prior to the pandemic and analyzed rather in the height of the pandemic, but it did not include data from the pandemic, which also draws me to say that there is a follow-up study that we have just completed data collection for, and we'll be doing a comparison and about the pandemic. Did this worsen the results? Is it the same, or is it any better now? While there's a lot of numbers on the slide, I just draw your attention to the numbers and types of groups that were studied within this group. And you could see how certain populations were oversampled to make sure that there was an understanding of what exactly was happening within those groups, as well as different ethnic backgrounds. What you see here then is after adjusting for the odds ratio, that there is definitely a spike within the American Muslim community as compared to others. And this really was telling, because before this, we had no real data points on what this meant and how to actually help this community. As I mentioned, the study garnered quite a bit of attention. There was a lot of interest in this topic, not just on social media, but also on many news outlets. And since then, there has been now probably over 100 stories on many, many different news outlets that captured this particular story. And there was always the question of why. What is happening here? And to us, to explain that this particular study that's published in JAMA did not ask the question why, rather we were trying to find quantitative data on how widespread this issue really is. If you look further into the research about suicide, you may be familiar with two main theories around the topic of suicide. The first has to do with the feeling of belongingness, or the lack thereof. And this is definitely a story of many marginalized communities in the United States, particularly the Muslim community that in many ways had been scapegoated in the social political atmosphere of recent times. The second theory has to do with an increased sense of burdensomeness. This too was quite common within this community, whether this happens on a personal, familial, or community level, or whether it's happening on a broader societal level, but both applied to the American Muslim population. And so we decided in the lab there needed to be a response to this. And part of my discussion today is to share with you not just bad news, but really what we did next. How did we respond to this difficult finding? One of the first things we worked on within the lab was working on something called the Muslim Community Suicide Response Manual. It's an iterative project. It has been several years in the making, and we keep iterating on it. What's unique about it is you have about 100 pages worth of a manual that is well-researched, both in the suicide, cutting edge research on the topic of suicide, but wed and coupled with the theological, moral, and ethical understanding related to suicide for the Muslim community. Here are some examples of what I mean by this. This manual is split into 4 sections. After the introduction, we have a section on prevention, intervention, and then postvention. Postvention is the word, as many of you know, that has to do with how to respond in the crisis aftermath of an unfortunate event of suicide. There is no such thing that had been created yet for the Muslim community. And in many ways, everything else that had already been created was not exactly fitting this community. There are certain ethical and moral and theological understandings related to suicide that really became more like a barrier for this community to really benefit from materials that were out there. So we felt we had to custom tailor this information for this particular community. While this is a long table of contents and I don't expect you to see every line on here, I'll just point out a couple of things. And I'll show some slides that have to do with the manual itself. As I said, it's broken down in these different sections, but particularly pay attention to the fact that there is discussion on the faith itself woven into the suicide theory and response that is accurate. Everything we had seen up until this point was either too secular, as in to say, those who are leaders within the Muslim community who are often responding to the topic of suicide felt it was too distanced from them, and they did not feel that it applied to this community. And other resources that we found were too religious, and they were not accurate in terms of a medical model. They were not the proper way to respond to suicide. So it left us with really nothing that was quite excellent in both aspects. Here is an example of what I mean in terms of customizing for this community. There are areas in which Quranic verses are incorporated, or hadith, the sayings of the Prophet Muhammad, peace be upon him. And there are topics that are very relevant, so that if there is a Muslim faith leader, such as an imam or a sheikh, who is reading this, they could see directly Islamic concepts so that they don't reject this conversation wholesale, such as the value of life in Islam, benefiting and balancing science and faith, Islamic mandates to intervene, suicide intervention, which actually could be something considered as from within the faith, and the responsibility of community members and leaders to respond to this topic. Now, as proud as we were of our work of this manual and creating it and the many years it took to create it, What we realized was it was very difficult to hand an imam or a leader in the community a 100-page manual and say, here you go, work with this in your community. It would be difficult for them to read this and actually implement it. So it was a good reference and resource, but we realized we had to actually do something else. So allow me to present our next solution to this topic. It is called Maristan, which for my lab, this is the nonprofit arm of our lab, where the lab is academic and Maristan is actually an organization that is community facing. It takes the academic research from within my lab and then takes it to the community in bite-sized pieces, if you will, to the lay public. First, let me explain to you very quickly. People ask me, what does the word Maristan mean in the first place? And this goes back to Islamic heritage and understanding. Speaking of custom-tailored information for the Muslim community, we thought it was fitting to have something that was directly from Muslim heritage. And so the Maristans, shortened word and Latinized word for Bimaristan. Bimara is the person who is ill, and stan is the place of. In Arabic, that is the Persian word Bimaristan, and in Arabic, this word would be Darus Shifa. These were the Islamic hospitals, or the hospitals in the Islamic era that started from the 8th century onwards. Everywhere Islam went, the Maristans followed. And what's unique about these hospitals is that, to our knowledge, they are the first in human history, to our knowledge and research, that actually incorporated mental health or psychiatric wards within their hospital systems. Many people today don't realize this. It's certainly not taught in your Psychology 101 courses, nor is it taught in your history of psychology courses. And this is unfortunate. There is quite a bit of rewriting the narrative that needs to be done so that it's understood the contributions of many different civilizations and communities to the topic of mental health. Certainly, this has been useful for many in the Muslim community to realize that that stigma and taboo of speaking about mental health actually should be bygones, considering the heritage Muslims had related to the treatment of mental health. I digress, but I'm just explaining the name Maristan and where it comes from and the history behind it. This particular organization works on 3 areas: clinical care, which we have a clinic here in the Bay Area, California, San Francisco Bay Area, in which it's a training clinic. A lot of the work that we do is educational, which I'll share much of it now. And the research is based on what happens in the academic lab at Stanford University. So after creating the manual on suicide response, we then decided there actually needed to be a training that was created next. That took the information from that robust research manual and then put it into training modules that were taught to community and faith leaders. We also realized we needed to create other resources, such as sermons for the Friday prayers that could be used and from the pulpit, literally, used to actually talk about mental health, including suicide. In the aftermath of a suicide, there is still a prayer and there is still a burial, and there is grieving by the community. And we thought to address all of that in a sermon that both balances the correct understanding of suicidology and the research behind it, but also balances the Islamic moral and ethical tradition. Excuse me. I will also share with you something called the 500 Imams Campaign shortly. The website is actually a resource as well. And if you go to maristan.org/Muslim suicide resources, you'll find that you can download the sermon directly, multiple articles on this topic, also definitions of what to do and don't do in the topic of suicide for the Muslim lay public. And there is now a training form that communities can ask for trainings. That brings us to what are these suicide response trainings that have happened, that have been created since. And similar to the actual resource manual, there are 4 sections or 4 modules to the training. Today, the way this looks is a full day, 8-hour certification training on the topic of suicide. And to date, we have trained about 250 people who are leaders in the Muslim community here in America on this topic, and we hope to train many, many more. Here is a little bit about what the suicide response training looks like. We have here, for example, the discussion of language when discussing suicide, also understanding demographics of the topic of suicide, and contextualizing it within the Muslim community. This is very important because even when we published the article on JAMA, we found that there were people within Muslim communities that pushed back against this and said, no, this cannot be. These numbers are not true. Excuse me. And they came from an ideological perspective of the faith is protective, how could this be? And what we said instead is, let us take this as an opportunity to really train ourselves and our communities in how to respond, as opposed to debating whether the numbers are there or not, because clinically, we could definitely see them. I apologize for my voice, that seems to be giving out. If you see here some of the module previews, you'll see that there is discussion on in prevention. What do you discuss and how do you say it? We talk about changing words like committed suicide to died by suicide and such, which goes along with the research, the modern research on this topic. We also talk about the importance of the do's and don'ts of language. For example, what do you say in the aftermath of a death by suicide in your community? And we tell them, and we kind of shape that conversation. For example, instead of saying things like, we have to just stop young people from succumbing to the darkness of suicide, and to change that to suicide is preventable. And we can come together as a community to avoid future losses. Though this may seem simple, you would be surprised how many times in faith communities, not just the Muslim community, but many others, in which the language in and of itself around the topic of suicide is heavily judgmental. And so we're careful to discuss how to change that conversation, starting with language. Much of what happens in the modules also takes their information. It's not just passive, it's very interactive. There are questions that the group is meant to answer. And there are also role plays that happen in terms of conversations. And it becomes this very interactive process so that somebody who goes through this training at the end of it feels that they really can help intervene for the community afterwards. Here's an example, a question that says, why is the following statement inappropriate? Jamal had a good job and 3 kids. I can't believe he just gave up and committed suicide like that. He must not have loved his family. Excuse me. We then ask people, why would this be inappropriate? And you see here the corrected statement that Jamal lost his life due to suicide. May Allah have mercy on him and give him strength for his family, give his family strength in this painful time. We have heard back feedback from those who have attended these trainings that sometimes just having the right words of what to say and what to do is very useful. Many of our faith leaders or community leaders or youth leaders have said they really want to help, but they just don't know how or what to say or how to react in a situation such as this. If you look at module 2 that talks about prevention, here we talk quite a bit about stigma and building a crisis response team. We have case studies, and these are very important in that they are situated within Muslim communities that look like the very people who are attending the training. So the story mimics what very well could be something happening in any one of the communities of the attendees who are going through the training. And there are group reflection times where they go into breakout rooms and discuss this. And so it says, if Imam Burhan called you, what would your immediate concerns or questions be? And they discuss amongst themselves, and there's role plays, and they really discuss how to address this in the Muslim communities rather than just brush this under the rug, as often seems to happen. We make sure that they understand everything that came through with these knowledge checks and give clear answers to those questions. In the module related to intervention, here is where so many people have found themselves needing to intervene, but not even knowing what the warning signs are. So we go through those red flags, we go through a suicide risk assessment for a community member. We also go through the referral process and how do you go to a mental health professional and when to call upon, what is the limit between what the faith leader can do and when the professional needs to intervene. Here too, we have case studies. And through this discussion, they're able to conduct a suicide risk assessment to understand the steps that needs to be taken and to learn when to refer. Also things like calm keeping strategies, how to make sure that a person is able to keep calm, who's a leader, to be able to then help those in front of them. We also talk about things like confidentiality and privacy. What are the limits of those things? And when does confidentiality, even to a faith leader, need to be breached? We also bring in the theological framework so that somebody who is a faith leader, an imam or a sheikh, could actually see this and feel that this applies to them. Often in years past, we would have so many imams who would say, this does not apply to me or my community. This doesn't happen here. When in reality, not only does it happen, but that faith leader, depending on how they respond, has a very important role in either preventing the suicide or in the healing and the unfortunate aftermath of a death by suicide in their community. Lastly, postvention is the crisis response. And here we talk about expert-derived strategies and techniques of what to do in the unfortunate aftermath of a death by suicide. Here we talk about the importance of the community's first responders, that when a tragedy strikes, there are many people in the community that really need to step up to the plate and to help. And so many people who are leaders don't realize that they have a very important role in this conversation within a community background. We provide stats, we explain the importance, right, of the role of the leaders. They walk away understanding their importance as first responders. All of our research in the lab, we've repeated study after study after study that has showed that when there is a mental health consideration, the first people that someone may go to is usually family and then friends in a Muslim community, followed by the faith leaders. This is way before they are willing to go to mental health providers. With this new generation and kind of a generational difference that is happening now, we're finding that people are starting to turn to mental health providers before their faith leaders, but this is just one study in a series of studies that have all showed that people tend to go to their faith leaders before mental health professionals when there is a mental health consideration. I do hope that we see a change in this trajectory. But until then, training the faith leaders and other types of leaders within a community becomes imperative because it is unique to this population that tends to go to family, friends, and faith leaders first when there's a mental health consideration. Here too, we bring in the theological frameworks and we make sure that people understand that there is more than just a public health discussion here, that they feel that this is coming from within, indigenous to their own faith understandings and frameworks. And there are discussions that often where there's a lot of confusion. Here is where we have these conversations with them, because we have seen in communities that there is so much stigma and taboo, not just to mental health, but especially to suicide. I call it the taboo within the taboo. That leads people to then want to, they're not sure, should we even do a prayer for this person after they have died? Should we bury them in the same cemetery as the other Muslims in the community? Shall we treat them and their families of the bereaved in the same way? Isn't this a sin? and so on and so forth. And so here we really have a clear conversation about where the theology is, where the science is, where the two meet. And also understanding the importance of helping and healing those who are the bereaved, those who are lost survivors, those who had a loved one die by suicide, and what to say and what to do. Often our faith leaders, it always says, never give a preacher a mic, a microphone, because they'll keep on talking. It's true. So many of our imams, they're naturally inclined to just talk and give advice, theological and spiritual advice. And we have to almost retrain them in a suicide loss incident to lead by actually listening and less by speaking and preaching. Also, things like, what do you say when you do come to speak? And being very careful not to cast any sort of doubt on a person's end state, theologically speaking. All of this, they end up actually talking about and taking, mini exams or quizzes throughout the trainings to make sure that everything that they learned is in fact something they're able to reproduce. And lastly, they go through a post-vention schedule that starts with day 0, what to do on day 1, what to do in the first 2 weeks after a suicide, what to do in the first few months. And we kind of lay out the steps so that it's a very clear step-by-step process of how to respond to the topic of suicide in Muslim communities. Our discussions here in terms of the sermon, which I mentioned is downloadable from free and downloadable from our website. We have written a few of these, one related to suicide prevention, which we encourage people here in America. We have Suicide Prevention Month is the month of September. And whenever there is a death by suicide, a post-vention sermon or khutbah. And these are also downloadable. And we have received feedback from imams who have actually used these. And in one case in particular, where the imam was really close to the person who died by suicide. And when he got up on the pulpit, on the minbar, it was very difficult for him, actually, because he was so overcome by emotions trying to give the Friday sermon, that he said he had downloaded our sermon from the website and just sort of read it word for word because he was so shaking by the incident. And he was thankful to have something there in print that actually fit both the correct understanding from a health perspective, but also from an Islamic guidelines perspective for that sermon. And so, we all wish that this didn't have to be the case, but certainly it will continue to be the case. And we're thankful that now resources have been created. What other resources do we have? There are articles that have now been written for the lay public. There's a website called Muslim Matters, which is a popular website with articles for Muslims. We have published a series there, one on suicide prevention, one on intervention, one on postvention. And there are tables there, such as this one of what to say and what not to say, and the top 5 things to do, the top 10 things to do, and so on and so forth. Here is the khutbah, the suicide prevention sermon that you're welcome to download as a resource for anybody who can benefit from it. And there are also academic papers in which we discuss, this one we just heard was recently accepted, in which we track different communities that have experienced death by suicide in their communities and really talk about kind of understanding a case formulation of how does the entire community cope with and heal after the grieving of a death by suicide. Both the cultural and religious factors, but also resource factors is what we discuss in these articles as a blueprint for other communities to be able to benefit from. Now, the question about what happens next, is there anything that's going to answer, is there some help or protective measures beyond the trainings, which hopefully will aid in prevention and postvention and such? There is a recent grant that we've received from the John Templeton Foundation that works specifically on the topic of Muslims and suicide and looks at the protective factors that may come from, Islam-inspired character and moral traits in which there could be some leveraging of protective factors. We're building out a biopsychosocial spiritual model on, psychological modeling of how exactly to help this community, and by extension, other marginalized communities, particularly those of faith communities, to be able to help leverage aspects from within the faith that's indigenous to the faith to really help in suicide prevention. Anecdotally, we hear often, and I've heard in my own clinic very often, people say, if it wasn't for my belief system, the theology that I believe, I would have died by suicide by now. That is a two-edged sword. There is definitely some preventative, helpful aspect to that, but there is also the shame and stigma and guilt that comes with that as well. And that is where the work that we're doing is trying to really dissect and pull out what is useful and what is not, but is actually indigenous to the faith itself. And lastly, I should mention, I would share with you something called the 500 Imams Campaign. In 2022, this year, we decided we wanted to train at least 500 imams or religious and community leaders on this topic. And we're halfway through the year, and I'm happy to report we're halfway through those numbers as well. In the state of America, the latest research on how many mosques are there in the United States, the number is 3,000. And so in our 5-year plan, we hope to reach all 3,000 is our hope. I would like to take the next 3 minutes to share with you a clip. And before I share this, I'll say that this is a promo clip. It is something that is a promotional video or tool in which we took many of the famous American Muslim imams, men and women, to talk about the topic of suicide. And I have to tell you before I play this clip, although you may not recognize everyone here unless you're more in the American Muslim scene, if you will, there are people from within the imams from within this clip who just some years ago, if I tried to have the conversation on mental health or let alone suicide, it was almost impossible. It was very difficult and stigmatized to have this conversation. But certainly the shifts that have happened, as I mentioned, social, politically, and certainly the tragedies we've seen in the last few years, I've also sensed a shift within our leadership. And so I will share this video with you, and I hope you'll get a sense of what I mean about the training that we're doing and also this promo. So if you'll bear with me a moment here, I'm going to play this.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Assalamu alaikum.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Cause Allah is always by your side.
According to CDC, there has been a 33% increase in suicides within the last 2 decades.
Suicide death occurs every 11 minutes in the United States, and for every suicide death, there are at least 20 attempts.
Our own Muslim community is not immune from this.
1 in 3 Muslims report feelings of suicide or thoughts of suicide in therapy.
There are so many challenges that Muslims face, which create concern for suicide risk. Among them, social isolation, racial and ethnic discrimination, Islamophobia, anti-Muslim assaults, and psychological distress.
Our community in Allen, Texas experienced a heavy tragedy when the lives of an entire 6-member household came to a sad end due to a murder-suicide. Now, although our community faced the brunt of that grief, the shockwaves were felt way beyond our city and our national borders.
When it comes to suicide, it's poorly understood in the Muslim community and way under-researched. And our imams are not well equipped to deal with these issues.
Unlike other medical-related deaths, suicide is 100% preventable with the proper support and tools.
And we of the religious community need to train our own leaders to be the first line of defense.
The good news is that the Stanford Muslim Mental Health and Islamic Psychology Lab has developed an evidence-based, in-depth suicide prevention, intervention, and postvention training.
The postvention or crisis response has been utilized in many Muslim communities throughout the U.S.
I was fortunate enough to attend Dr. Rania Awaad's emergency suicide postvention training.
I myself have attended an online session and found it very beneficial.
I felt very blessed to have attended and wished that more of our community members, in particular our religious leaders, could also benefit from the powerful and critical training that we received.
I came out of that phone call with an outlook on the issue of suicide that we don't really study in the books of tradition.
I benefited from that session, but I know that so much more needs to be done.
I urge you to back this project. I urge you to contribute towards this project.
Please support Let Us Stand's mission to train 500 religious leaders by 2022.
We want you to give to this cause generously because it's extremely important and valuable, and it's life-saving, wallahi, life-saving training.
It's our responsibility to prevent any other suicides in our respective communities.
And remember that Allah subhanahu wa ta'ala tells us that whoever saves one life, it is as if he has saved the life of all of humanity.
And you won't know whose life you will be changing or whose life you will be saving.
Please be sure to share this campaign with your friends and family. Jazakumullahu khairan. Wassalamu alaikum wa rahmatullahi wa barakatuh. Thank you.
All right. So I hope that was a useful kind of just view of what this program is all about. And again, forgive the promotional aspect or feel of that particular,
Assalamu alaikum wa rahmatullahi.
hang on, there we go, of that promotional video. But what it was really there for was really to inspire members of the community, particularly our religious and faith leaders, but also other forms of community leaders, to also partake in the study, in the training rather. We felt very strongly that if you could have the main faces of the leadership within the American Muslim scene, that we could actually then maybe be able to encourage all leaders to really understand the importance of a training like this and be able to take it. So as I conclude here, I would just like to say that what we've learned in this whole process is several takeaways. Number one is that there needed to be research. There needed to be data points that you can point at and say, here are what the numbers actually look like related to this. Anecdotal evidence simply and clinical evidence simply wasn't enough. We also learned that there needed to be, very instantaneous emergency suicide for the larger, not just the bereaved, the actual family, the lost survivors, but the entire community that was feeling the shock waves of that grief, as was mentioned in the video. We also learned that because suicide is something that actually, if we could see the red flags and actually intervene early enough and understand what those red flags were, we could potentially prevent the work, increased levels of suicide. And lastly, we found it was very important to understand that this understanding of trust within a community that had to be culturally adaptive and religiously congruent for it to even be taken seriously within the community, but also had to be something that was evidence-based and met the medical and suicidology kind of research level of this topic. There had to be an integration of both things for this to really take traction and have the form in which we have today. And so religious and cultural congruence becomes very important for efficacy. I would like to say that in concluding here, that there is, we are definitely studying the work of this training. We have received IRB or ethics approval from Stanford University to study pre and post studies related to this topic of the training to see whether it is actually making the impact that we hope that it's making, so that we can then test its efficacy and its scalability over time and space. And so with that, I'll conclude and welcome you to welcome some questions, but also welcome you to stay in touch and certainly to use any of the resources that we've made available. I hope they're useful to you and those around you in your communities. Thank you very much.
Yeah, thank you, Rania. This is working. Yeah. Thank you, Rania, for this great presentation and for this really amazing work you are doing. I don't see you anymore. Where are you? Okay. What do you know about Europe? Is this situation in Europe the same as in the US?
What I have to say about Europe is that we don't have enough research just yet about the European Muslim community. This would be another stage of work. Anecdotally and clinically, we can say that the numbers look similar, but we don't know until there's actual data and studies that have been conducted.
Okay, so you look for cooperation there.
Certainly.
Yeah, sure. Sure. There are questions now from the public and also from the chat. Maybe you can read them.
Yes, Rania, here's Arjan Braam. I will read for the audience also here the questions in the chat, but you can also read them, I think, yourself, but I read them now for the audience. The first step is by Ainul Madja. What steps do you take to build the intervention that not too distant from Islamic teaching and which are not too religious for Muslims? I mean, how to find the sweet spot of balance?
Yes, it's a great question, and I thank you for the question. It is, in fact, a sweet spot. And certainly we've had questions like, what about a person who is Muslim but not practicing, or somebody who is identifies culturally as being a Muslim, but not so much in the observance of the faith itself? And so the manual and the training that you'll see, we definitely, I would say it's Islam inspired, as in to say it's taking from the faith framework, but in and of itself is something that really applies to really all people. In fact, we've had recent conversations about scaling this training to other faith communities or other marginalized communities, because the understanding of the two theories I mentioned, which is the increased sense of burdensomeness and also the lack of belonging, is something that is shared actually across many different marginalized groups. And because of that, if you take away some of the theological aspects, the rest of the training, honestly, is something that's very applicable to so many people. So that is something we hope to do. And I think the way it stands now, for at least for the Muslim communities, you'll find that it's something that hopefully does hit that sweet spot, as was asked.
Yes, I feel here in the audience the same feeling that many of your principles apply to the Christians or other religions as well. There is a detailed question by Katja Milner. She has a case for you, thanking you for your lecture. She says, a Muslim research participant recently shared that within his community, mental illness was not viewed as being real. It was not discussed, and that any treatment was viewed as only being religiously focused. Do you have any reflections on this, and how can this be worked with in relation to your project?
Yes, thank you for the question. Definitely, I would say that this is a sentiment that we have seen all throughout our work. In fact, the reason there is even a lab called the Muslim Mental Health and Islamic Psychology Lab is specifically for what you're mentioning, that there are many within this community and others and other faith communities that will look at psychological ailments as being spiritual and only spiritual, and not take it seriously, not understand the multifactorial understanding of what mental illnesses causes mental illness. And so a lot of the work that we do is specifically combating the myths related to this. Also, the reason we called ourselves in the nonprofit organization Maristan and bringing the heritage back is to say to the community, stop pushing on this being a spiritual issue. You have a heritage in which not only was the biological, physiological, environmental causes of mental illness recognized, but the treatment and entire treatment wards and standalone mental health institutions were created within that early Islamic civilization for a reason, right? And this included things like, not to take too much extra time, but just quickly to say things like talk therapy, things like music therapy, in which we have several papers coming up on the topic. Before there was even a field called music therapy, or before something like cognitive and behavioral therapy became a thing, right, in the modern era, we have papers showing that there was not only CBT and exposure therapy like therapies that were introduced in that early Muslim society, but actually practiced and utilized. And I encourage anybody who's more interested in this topic to look at some of the papers published by my lab. We use this all the time in discussing with the Muslim community and pushing back on any of these taboos and stigmas they have against mental health by talking to them from within their own tradition. So I hope that's helpful and useful.
Very good to know, and it answers already another question by Sri Padmasari about the stigma. So I go to the final question in the chat, if it's okay, Renee, by Ainul Madhya, and she asks you, based on your experience working with Muslims, which one is more effective, directive or non-directive approach? Bless you and your work. So the blessing you have already here, now still your answer, directive or non-directive?
Yes, thank you so much. We have found that on the topic of suicide, directive work is much better. The reason for this, and I'll tell you, about 10 years ago or more, when we were first doing some of the work in the American Muslim community around the topic of mental health, we used the non-directive approach. We would couch these topics of mental health into things like wellness and parenting and just words that weren't very direct about mental health, because we found that some years ago, when we were first starting this work, if you had a topic such as substance abuse and Muslims or suicide and Muslims, nobody would show up. It was too far and distanced. Now, especially after the pandemic, there has been much more of not just a American awakening, but really a societal, a global awakening for the topic of mental health. And we're finding that people are much more willing to have a direct conversation related to this, and where I can enter into a Muslim community and talk about very heavy topics like suicide and mental health. And there's still a lot of change that needs to happen. This is still an uphill battle. We're not fully there yet, but it's certainly much, much more amenable, and we're able to be much more directive than we've ever been able to before. And so if anything, it's a bit of a silver lining of this pandemic to speak very directly and directively about mental health.